Hi, I'm Dr. Joe Sucher with the Arizona Trauma Association, and this is Trauma in a Flash. Burn injuries continue to be one of the leading causes of unintentional death and injury in the United States. In 2016 alone, there were nearly 3,400 civilian deaths from fires. That translates into one civilian fire death every 2 hours and 35 minutes. The primary causes of burn injury include fire, electrical, scalds, contact with hot objects, and chemical contact. Tragically, children and the disabled are especially vulnerable to burn injuries. Almost 1/4 of all burn injuries occur in those under the age of 15, and burn injury was the 8th leading cause of death in those over the age of 65. Burns are classified based off the depth of injury. First-degree burns only affect the superficial epidermis. A first-degree burn is painful, pink, and slightly edematous. The pain will often subside with simple cooling of the burn area. Second-degree burns can be classified as superficial or deep based on the depth of injury into the dermis. The superficial second-degree burns are painful, red, blistered, moist, and more edematous than a first-degree burn. Deep second-degree burns appear both white and red, will have a lack of hair to the area, and may or may not be painful. Third-degree burns injure all layers of the skin, including the epidermis, dermis, and subdermal layers. Third-degree burns also involve the nerves that supply the skin. Therefore, they aren't painful. Color ranges from white to black, and skin will be dry and leathery. Fourth-degree burns include injury to the subcutaneous fat, muscle, or bone. The size of the burn is measured as a percentage of total body surface area affected by partial thickness or full thickness burns. First-degree burns that are only red in color and are not blistering are not included in this estimation. There are a number of methods to determine the total body surface area, including the Wallace Rules of 9, the London-Browder chart, and estimations based on a person's palm size. The rule of nines is easy to remember, but only accurate in people over the age of 16 years of age. More accurate estimates can be made using the Lund and Browder charts, which take into account the different proportions of body parts in adults and children. The size of a person's handprint, including the palm and fingers, is approximately 1% of their total body surface area. Burn care starts with the first responder. Small burns, such as a burn to the hand, can be covered initially with gauze and saline. Wet, cool dressings feel better, and there is very little likelihood of developing hypothermia from a burn to an isolated area. However, for transport purposes, the general rule is that once the burning process is stopped, serious burns should be covered loosely with dry dressings. This can be accomplished by putting clean, dry sheets, sterile if available but not mandatory, under and over the patient with a blanket on top to prevent heat loss, even in the summer. The rationale for dry dressings is that they cover the burn but do not add to potentially life-threatening hypothermia. As a rule, burn centers teach dry dressings for everyone. There are burn dressing products. These are typically gelatinous dressings composed of sterile water and tea tree oil. They are safe for patients with large burn wounds. However, in cases where transport times to definitive care are quick, they likely don't represent a significant benefit, especially from a cost perspective. Silver sulfadiazine, Silvadene, though commonly used for burns in the outpatient and inpatient hospital settings, should not be placed on the burn by EMS or transferring to hospitals, as the receiving staff will have to remove the dressings and the Silvadene to assess the burn. Just remember, when in doubt, apply dry dressings and transport for immediate care if possible. Thank you for watching this week's episode of Trauma in a Flash.